Welcome everyone. Today we embark on a journey to explore the complex, puzzling world of schizophrenia. Schizophrenia, often associated with lots of misconceptions, is not just a disorder, but it's a journey of the mind where the boundaries between reality and imagination blur and it almost challenges our very perceptions of what it means to be human. In this video, we'll be focusing on the clinical symptoms and subtypes of schizophrenia. We'll also look into the brief history of schizophrenia. Young adulthood is when we experience many things for the very first time, like independence, romance, driving, and sadly for some, their very first episode of psychosis. Psychosis, as you all know, is a loss of contact with the reality in which a person's thoughts and perceptions are disturbed. And psychosis marks the onset of schizophrenia, a challenging mental illness. As you can see on the slide, schizophrenia is a complex and disabling brain disease with psychotic manifestations, cognitive dysfunction, and profound psychosocial impairment. It typically manifests in late adolescence or early adulthood. Early intervention is crucial as research shows the first few years after these symptoms emerge are very critical for the effective treatment. And if left untreated, schizophrenia can lead to a range of complications. The longer it goes without intervention, the greater the risk of these issues. The World Health Organization recommends treatment within 90 days of symptom onset, highlighting the critical importance of early care in schizophrenia. Rich descriptions of psychotic disorders resembling schizophrenia can be found throughout written history, with early Greek physicians documenting cases similar to its current form. The concept of psychosis as a medical condition suitable for scientific study and treatment emerged during the 18th century in Europe. Kraepelin laid the foundation for modern psychiatric diagnostic systems by distinguishing between organic psychosis and primary psychotic disorders. He introduced the categories of manic depressive psychosis and dementia precox, which is now known as schizophrenia. Bleuler introduced the term schizophrenia in 1911 and focused on splitting of psychic functions as schizophrenia's core feature. He described the primary and secondary symptoms and considered the loss of harmony among thought, emotion, and behavior as the hallmark of schizophrenia. Schneider attempted to make the diagnosis of schizophrenia more reliable by identifying specific characteristic symptoms known as first-rank symptoms, which includes hallucinations, thought disorders, and delusional perceptions. And these differing conceptualizations and diagnostic criteria for schizophrenia led to variations in diagnosis rates globally, prompting efforts to establish more formal and reliable diagnostic criteria, leading to the current modern nosology. The historical evolution of schizophrenia diagnosis underscores the complex and evolving nature of our understanding of this particular mental disorder. Here you can see Schneider's conceptualization of schizophrenic symptoms. Moving on. The second edition of DSM-2 heavily influenced the diagnosis of schizophrenia in US and it was influenced by the Bleuerian criteria. The adoption of Bleuler's criteria led to broad and arbitrarily applied diagnostic criteria, resulting in high rate of schizophrenia diagnosis. Many conditions which is now classified elsewhere was included in the diagnosis of schizophrenia at that time. That led to this increased incidence in schizophrenia. And studies conducted in 1960s and 70s in US and Europe revealed very low reliability of schizophrenia diagnosis, with US having much higher rates compared to Europe and all. And US conducted cross-national project which showed significant differences in schizophrenia diagnosis rate between many countries. And this indicated a need for more standardized diagnostic criteria. The international pilot study of schizophrenia, sponsored by WHO, interviewed about 1,200 patients with psychotic disorders from 9 countries, and it demonstrated that schizophrenia presented similarity across diverse cultures, leading to the belief that uniform diagnostic criteria could improve the communication among clinicians and researchers. The shift from DSM 2 to 3 marked a significant departure from previous diagnostic systems and set the foundation for the current diagnostic criteria for schizophrenia. This change was influenced by efforts to increase the validity and reliability of diagnosis, and particularly by the research diagnostic criteria, which is called RDC. The RDC introduced a reduction in the duration of active symptom phase required for diagnosis, emphasizing the temporal length of psychopathology and differentiating based on presence of mood symptoms. The DSM-3, published in 1980s, defined schizophrenia more narrowly and incorporated Schneiderian concepts and introduced a multi-axial diagnostic system. And clear exclusion criteria was described with a maximum age of onset at 45. This criteria was eliminated, and principles guided the development of subsequent editions of DSM, including DSM 4, DSM 5, and all. DSM 3 introduced a requirement for symptoms of at least 6 months duration as part of the diagnosis. Schizophrenia has seen evolving conceptualizations from its inception in late 19th century to the most recent ICD-11 publications in 2018. Despite advancements in our understanding, schizophrenia remains a complex and enigmatic condition with no established biological markers for diagnosis. And the categorical approach, with following the principles of biomedical model, has traditionally framed the understanding of schizophrenia. The categorical approach has shown limitations in diagnosing cases with overlapping symptoms and highly comorbid conditions. Okay, and a dimensional approach, which acknowledges a quantitative and gradual variation between mental disorders, is emerging as an alternative model for understanding schizophrenia. The dimensional approach places schizophrenia within the psychotic spectrum, emphasizing shared etiological factors for psychotic illnesses. ICD-11 and DSM-5 has started to incorporate elements of dimensional approach, introducing symptom specifiers and a broader perspective on psychotic disorders. Changes in the name of schizophrenia have been proposed due to stigmatization and associations with hopelessness and violence among these people. Movements advocating for a change in the name of schizophrenia have proposed alternatives, and some countries have already adopted new names for the condition. The conceptualizations of schizophrenia in ICD-11 aligns more closely with the approach in DSM-5, with changes in diagnostic criteria and specifiers. Despite changes in description, the core definition of schizophrenia remains consistent between ICD-10 and ICD-11. Catatonia is managed differently in ICD-11 and DSM-5, with ICD-11 considering it a symptom specifier category and DSM-5 treating it as independent specifier. DSM-5 requires 6 months of illness duration with at least 1 month of active symptoms, and ICD requires only 1 month of total duration. DSM also mandates a deterioration in social and occupational function as part of diagnosis, while ICD does not have this requirement. ICD includes a category of simple schizophrenia, which does not require the presence of psychotic symptoms, unlike DSM. All subtypes of schizophrenia were eliminated in DSM-5, and the symptom threshold for diagnosis was raised to at least 2 core symptoms, which includes delusions, hallucination, disorganized speech, grossly disorganized or catatonic behavior, and negative symptoms. And DSM no longer gives special diagnostic importance to first-rank Schneiderian symptoms, treating delusions equally regardless of content. And Both DSM and ICD aim to provide a more specific and standardized criteria for the diagnosis of DSM. DSM requires the presence of significant deterioration in one or more major areas of functioning such as work, interpersonal relation, or self-care as part of the diagnostic criteria as mentioned just before. In contrast, ICD does not require functional deterioration and suggests that deterioration is not inevitable for a schizophrenia diagnosis. And looking into the duration, DSM specifies a total duration of 6 months for the diagnosis of schizophrenia with at least 1 month of active phase, and shorter duration of the active phase is allowed if successful treatment is initiated. Okay, DSM has this criteria, and ICD on the other hand requires only a minimum duration of 1 month excluding the prodromal phase and without considering treatment as a factor to shorten the duration of the acute phase. If this duration requirement is not met, a diagnosis of acute schizophrenia like disorder is made. And DSM excludes a diagnosis of schizophrenia if mood and schizoaffective disorders are present. Mood episodes should not coincide with active phase symptoms, and the duration of mood episodes should be brief relative to the duration of psychotic illness, including the residual symptoms. ICD allows for a diagnosis of schizophrenia even if the patient experiences depressive or manic episode, as long as the criteria for schizophrenia were met before the onset of the mood episode. And both DSM and ICD include exclusion for criteria for cases where symptoms results from substances, drug abuse, medication, or other medical conditions. And these points outline the key differences in diagnostic criteria for schizophrenia between DSM and ICD. Okay. Moving on to schizophrenia subtypes. DSM eliminated diagnostic subtypes of schizophrenia while ICD-10 still used Kreplin's original classification system. Schizophrenia subtypes have been considered controversial constructs with limited clinical utility, and these subtypes have a weak relationship to biological variables, poor long-term stability, and poor predictive value. Okay. So the paranoid subtype of schizophrenia shows greater stability than other subtypes and is still used more often in clinical practice along with the undifferentiated type. However, the clinical utility of the subtypes remains questionable. And instead of subtypes, DSM-5 introduced the clinician-rated dimensions of psychosis symptom severity, which allows quantifying the 5 core dimensions defining schizophrenia spectrum disorder, as well as assessing impaired cognition, depression, and mania. Each dimension is rated on a scale from 0 to 4, and this provides a more comprehensive assessment. Catatonia was designated as a separate category in DSM-5, which can be linked to multiple disorders including schizophrenia, schizoaffective disorder, and mood disorders. Okay. Moving on to the symptoms. Schizophrenia diagnosis became broadly applied and led to varying conceptual orientations among psychiatrists in the 20th century, and it became essential to define which symptoms were associated with which illnesses to apply the right treatments and determine treatment responses. Rating scales for psychiatric disorders like the BPRS, Brief Psychiatric Rating Scale, and the Present State Examination were developed to quantify symptoms and treatment responses. And studies using rating scales reveal the distribution of symptoms and provide insights into the disorder's parameters. Factor analytical techniques identified 3 dimensions or subsyndromes of schizophrenia, which includes psychotic symptoms, negative symptoms, and disorganization symptoms. Psychotic symptoms, including hallucination and delusion, define schizophrenia for the general public and many clinicians, but there is no single symptom that alone justifies a diagnosis of schizophrenia. Psychotic symptoms aid in diagnosis and serve as a marker for treatment response, but the focus on treating positive symptoms must not ignore the facets of the psychopathology of schizophrenia. Psychotic symptoms are not synonymous with positive symptoms and should be restricted to hallucinations and delusions. The focus on psychotic symptoms led to the emphasis on high dose medication treatments, which can have unforeseen costs such as secondary negative symptoms, dyskinesia, and medical complications. So here you can see some of the major positive and negative symptoms of schizophrenia. With that, we conclude this video. We'll be looking into these symptoms in detail in the next part of the video. Thank you for listening.